Good evening, everyone. It had been an immense pleasure traveling with you all for the last 3.5 months in the form of IPNA Endorsed Webmaster Series 2020. And so today we have come to the end of the session. Today is our last webinar with special invitees. Today we have two eminent speakers, and Dr. Kanwal sir is joining us for the session to give his closing remarks. The first on the row is Dr. Kanwal Kher. Dr. Kanwal Kher is a Professor Emeritus George Washington University School of Medicine, and he is a former chairman Division of Nephrology at Children's National Medical Center, Washington, and Phoenix Children's Hospital. And his specific academic interest is towards healthcare quality and utilization. And it is a great pleasure to hear from him about podocytopathies in children. Over to Dr. Kanwal Kher.
Good evening, everyone. And again, thank you, Dr. Ganesan, for inviting me into this webinar on podocytopathies. When she suggested actually the topic, I was quick to grab it because this is a subject very close to my heart. As a pediatric nephrologist, we all the time deal with nephrotic syndrome and proteinurias, and this is certainly a refinement of that definition into one entity, which is now called as podocytopathy. I have no conflict of interest to declare, although I have received funding from several pharmaceutical companies in past, which are listed down here. In terms of our objectives, I would like to define what podocytopathy truly means and what would be something that can be considered as a clinically defined and a working sort of a definition of podocytopathy. Then we will talk about some very unique characteristics and molecular mechanisms within podocytes themselves. And thirdly, talk about what injury to podocytes really means and how the outcome is generated, and are there any diagnostic tools that we can use. Lastly, and quite briefly, not in great detail, we'll talk about some treatment strategies as to how do we deal with these patients that come to our attention. Just a little bit about who I am and where I come from. My humble beginnings began in Maulana Azad Medical College in New Delhi, where I did my MBBS as well as my MD. I then came over to the US and started my work at Montefiore Medical Center in New York, part of the Albert Einstein College of Medicine. And many people do not really know what I did next, which was actually, I was quite interested in hematology, actually, and actually went and joined the Memorial Sloan Kettering Institute in New York. But it so happened that I was faced with mortality around with me in all of those patients, and I mentally couldn't take it. After a very short stint in that fabulous institution, I took care of some very unique patients there, both oncological and bubble babies, in fact, with severe combined immunodeficiency states, which are typically known as bubble babies. It was a wonderful experience, but I just couldn't take it. So I switched over to nephrology, what I could do actually something for the patients. And that landed me in Cleveland, and under the guidance of Dr. Walter Hyman, after whom is named the famous model of membranous nephropathy known as the Hyman nephritis. He trained me as an immunopathologist with interest in clinical medicine as well. After a lot of places that I went over and established some new programs, I finally landed up in Washington, D.C. at the Children's National, where I stayed for almost 27 years. Of those 27 years, I chaired the division of the Department of Nephrology for 24 years. and really built into a powerhouse of both basic research and clinical activities. One of the landmarks that I established there was the division of inherited diseases, renal inherited diseases, under the leadership of a very prominent person of that field, Lisa Gay Woodford, who's running that division now. Then I was lured into going to Phoenix, Arizona to do the same or replicate the same sort of rebuild of their own nephrology division, which I did in 3 years. And then I really didn't like the hot weather of Arizona and wanted to leave, and I left at the end of 3 years. Right now, I am exploring the other part of my training, which is via my MBA, which is to look at how do we improve healthcare in both quality and its deliverance in a company called Concentra here in San Francisco. In that process of going through different institutions, as I said, at Children's National, I spent my most time, and that's where I found the time to do an MBA. And I was actually also trained at Harvard Business School in some aspects of healthcare over some years. So that's what I'm utilizing at the moment and trying to improve deliverance of healthcare to general population as such. Let's begin with where we have been and where are we headed towards. The first descriptions of glomerulus were done by Malpighi in 1666. And he utilized microscopy. The next event, almost 100 years later, was by Morgagni, who actually described the clinical correlates of atrophic kidneys with the symptoms of uremia. William Bowman then described the Bowman's capsule surrounding that Malpighian corpuscle under microscope. And by the way, Dr. Bowman was not a nephrologist. He actually was a very famous ophthalmologist, but had an interest in nephrology, at least in the early part of his career. The sequence of events really picked up in mid-1940s when renal biopsy became available. And thereafter, under Dr. Walter Hyman's lab, they basically developed the models of various types of nephrotic syndrome. And that's when nephrology truly began in terms of picking up speed. Yet, it has taken almost a significant amount of, almost a 50-year time period to come to where we are at this time, where the discovery of nephron and the underlying molecular mechanisms of renal disease are being understood. A working concept of podocytopathy, I really like this definition by my good friend Jeffrey Kopp from NIH, who published this in summer of this year. He describes podocytopathies as kidney diseases with direct or indirect podocyte injury, which drives either proteinuria or nephrotic syndrome, which is what, if you really look about a very rough definition of podocytopathy should be. We all deal with these issues, but it has now been gelled into a concept of defect or degeneration or injury of one particular cell, which is podocyte. And truly, that's where the attention has been diverted into. And this is all we do all the time, but we are now beginning to concentrate our attention to the injury that podocytes go through and how does that relate to these progressive disorders that eventually lead on to end-stage kidney disease. What ought to be included in the definition? Everything truly, with whatever causes proteinuria, ought to be a part of the definition. For us as pediatric nephrologists, A lot of these genetic variants, diffuse mesangial sclerosis, congenital nephrotic syndrome, Alport syndrome, minimal change disease, focal sclerosis, collapsing glomerulonephritis, immunopositive or negative forms of glomerulonephritis, and for adults, particularly aging, diabetes, and hypertension, really are important aspects of this evolving field. My frustration with the definition of podocytopathy is very evident in the third edition of my book, where the authors actually mishmashed, and I'm a critique of that. We had a lot, I certainly had a lot of difficulty in accommodating this definition, but basically there are genetic aspects of it. There are secondary podocytopathies due to other injuries that the glomerulus is going through, and then there are the idiopathic ones. This is sort of a basic concept of thinking. I certainly had a problem describing primary glomerulopathies and idiopathic podocytopathies, almost similar sort of diseases. I had some difficulty with that definition, but the authors of this chapter persisted, and I said, okay, let's keep it. We will go over this type of classification, how we ought to be classifying at a later stage. How often do we see podocytopathies, and what's the prevalence of this disease? Obviously, we cannot pick every single entity that's included. Here are a couple examples. Again, I've taken this from Jeffrey Kopp's work related to minimal change lesion distribution throughout the world. And I was struck by the fact that minimal change lesions are much more common or prevalent in India, Australia, and some parts of Europe as compared with Northern America, which was something that I did not know. My general concept when I had looked at the prevalence of minimal change disease many years ago was about 4 to 5 patients per 100,000 population in the US. My general impression was that it's a similar sort of distribution that I'd seen in India as well. But the data kind of shows a little higher prevalence in India. On the other hand, focal sclerosis is much more common in the United States, perhaps because we have a large population of African Americans who are somewhat predisposed to it, although India also has a significant proportion of patients. In the next few slides, we'll try and understand what podocytes really are. We're all familiar with the electron microscopic picture with the glomerular basement membrane and podocytes lining on the outside on the urinary side and the capillary lumen being here. What is important to understand is that podocytes are a very complicated cell. They present themselves with a very nice outlined body. Then they have primary divisions, secondary divisions, and tertiary divisions, which actually form the podocytes that we see in electron microscopy. One point that I would absolutely like you to keep in mind that these podocytes from one particular cell always interdigitate with podocytes of another cell. They do not interdigitate with cells of their own kind. In other words, if this is podocyte from one cell, this has to be a podocyte coming from another cell. Same cell, another cell, same cell, another cell. So this interdigitation process, in my view, is a very elaborate mechanism of cellular talk between various types of podocytes that are in that particular glomerulus. As you know, podocytes do allow us to have some degree of sperm selectivity regulation. It is the slit diaphragm that allows or does not allow the passage of certain macromolecules from the capillary lumen onto the urinary space. Podocytes are also involved in providing a mechanical support to the GBM. Many of you may know that podocytes are also equally involved in forming the GBM. About 2/3 of the GBM is actually manufactured by the podocytes themselves. And also transition of the juvenile form of GBM, which is basically consisting of alpha-1, and alpha-2, collagen type 4, to the adult variant, which is 3, 4, and 5. All that switch happens because of podocytes. Therefore, podocytes are extremely important for remodeling of the glomerular-basement membrane. Whatever filtrate comes out of the capillary, and a lot of proteins are also filtered. They're all picked up by the podocytes and then brought back to the amino acid pool within the body. And as I mentioned, they are extremely important to prevent the mechanical stretch and resist the pressure, the mechanical pressure within the capillary lumen, and maintaining its shape as well. Other unique characteristics of podocytes are that they are highly differentiated. They're almost like neurons. Occipital neurons would basically deal with vision. The auditory neurons would deal with hearing. The motor neurons would do with motor activity. Same is true of podocytes as well. They cannot do anything other than what they're designed to do. And they're also terminally differentiated. They cannot multiply themselves. They cannot proliferate. They are in a very cell cycle quiescence period. They just do not proliferate. So the end point of all of that is that if there is damage to podocytes, you will not have proliferation of the surrounding podocytes. So what is lost forever. That's the important message that I would hope would be carried forward, because to preserve podocytes is to preserve the renal function in our patients. How did we get all interested in podocytes? The journey began in 1988 with the birth of a boy called Tony in Finland, who developed proteinuria, and because congenital nephrotic syndrome was well described there, the Finnish variant, he was diagnosed with congenital nephrotic syndrome and eventually underwent a transplant. But his pediatrician was very persistent. He knew Carl Trageson at Karolinska, who decided to look at the genetics of this patient and also then gathered 29 other families. They localized a defect somewhere on chromosome 19, specifically on 19q13.1. So they knew that something was wrong, and they named this particular gene, or that segment of the gene, as NPHS1, nephrotic syndrome 1. They didn't know what it was. And the product of that gene, which they didn't know at that time what it was, they just labeled it as nephrin. Eventually, their next step was extremely time-consuming, labor-intensive, and very, very clever. What they did was that they actually took pieces of those genes and hybridized E. coli to form the product of that gene, which turned out to be nephrin. And that product that they derived, purified that protein, then injected rabbits with that particular product protein and developed antibodies to it. Fluorescent tagged those antibodies and then took a 2-month-old human kidney and layered it on and looked at where does it localize. They found that the antibody that they had generated localized on to the capillary wall. So they had the first success there, but it was a very, very time-consuming and labor-intensive process. So they determined the gene, they found its localization somewhere in the glomeruli. After that period of time, there has been an explosion of information related to podocytes, nephrin, and other genes and other proteins have been classified existing within the podocytes. a true explosion of knowledge. This is a slide, again, to show you how complex the podocyte itself is, how many proteins, how many genes exist at every single level. This is just to give you an overview of what we deal with when we talk about podocytopathies. Anything of the number of genes can get mutated. Any number of proteins can be misformed. So a lot to learn still on this end. Very simplified view of the molecular anatomy of podocytes is as follows. This is very diagrammatic. It really doesn't represent true picture, but will hopefully convey the meaning of what I want to say. The basic proteins are either in the Slit diaphragm, which are essentially nephrin, Neph1 and Neph2, PCAD, and then there are the intracellular elements. Most important of that is the actin cytoskeletal structure. These actin molecules are bound together by actin and 4, which is a bridge. And if that bridge is broken, the whole cytoskeletal system breaks down. Then there is the anchoring of the podocytes. Those proteins are either integrin, both alpha 3 and beta 1, and dystroglycan. Both of these are the anchoring proteins. And it's not just the anchoring process. They also communicate with the interior cytoskeletal structures, actin, via different receptors. One protein that is completely intracellular is the podocyte. It has no element that is outside of the cell. It has no extracellular element, yet it is able to communicate with not only the extracellular component of nephrin, Neph1, and Neph2, but also is very important in communicating with CD2 associated protein, what is known as CD2AP, and other proteins within the communication cascade of the podocyte itself. So with this, I hope you can get a very brief but somewhat simplified version of what exists molecularly within the podocytes. To just again re-emphasize the fact that the anchoring of the podocytes onto the glomerular basement membrane, particularly laminin, would be beta 1 and alpha 3 integrin, and fibronectin with the dystroglycan, alpha and beta components. These are the anchoring proteins, and anything going on wrong or mutations here would lead up to inability to keep podocytes in their place, and these cells would basically fly off and die. This is again a version of the Slit diaphragm proteins, nephrin of one podocyte in line with nephrin of another podocyte. This is the intracellular actin molecules with actin and 4 and other two Neph1 and Neph2 molecules that form the podocyte slit diaphragm. A little bit about the actin structure within the podocytes, the cytoskeleton. Many members are important here, but of those, the actin filaments are the most important. There are two types of actin filaments. One, those run longitudinally along the whole podocyte itself, and then those bundles that circle the podocyte structure around and give the configuration of podocytes as they look on electron microscopy. These bundles are also equally important in anchoring podocytes onto the GBM. Other anchoring proteins and cytoskeletal support are listed here. Again, those molecules are not completely shown here. An important aspect of the actin cytoskeleton is that at the end of the day, actin receives multiple inputs from all proteins, both extracellular and intracellular, and ultimately is responsible for a lot of functionality and good health of podocyte. If something goes on wrong in any of those signals, then actin gets disrupted, as is shown here. This is the normal actin filament layering in a cytoskeletal, I guess this is a tissue-grown, outside the body podocyte with nice podocytes, and right next to it is a E-phase type of podocyte which has been injured and showing the disrupted actin layering. So if anything goes wrong with actin, it ends up with bad health of podocytes. So actin is really important in the overall health of podocytes. This cartoon basically summarizes what I have just described. These round forms of actin. There are two types, as I said. One is the round that surrounds it and gives it the tubular shape, and then there are the longitudinal ones. And if anything goes wrong with the actin cascade, then you have effacement of the podocytes and further on damage. What type of injury response should we expect? There are three different variants of response. One would be foot process fusion. That's probably the most benign response of podocyte injury. The second one is podocyte hypertrophy and swelling. And lastly, the most devastating one would be the podocyte detachment and apoptosis, therefore losing podocytes from the glomerular basement membrane. So I guess this is a gradation of the type of injuries that we might see. Let me talk for a moment about the slit diaphragm as we have known for years now, and what does it really mean? One of the earliest descriptions of slit diaphragm was by Rodewald and Karnowski in 1974. It was a very novel concept. What they did was they did high-powered electron microscopy and found that there was a central core with parallel but perpendicular type of something holding that central core together. They called that central core as the central filament, and thought that these were pores through which filtration was actually happening. They described it as about 40 angstrom width, and therefore developed what was known at that point a isoporous model of filtration, which has not really been proven to be correct in the long run, but it was certainly a first attempt at defining what is in those slit pores. This was the Karnowski model of isoporous membrane, thinking that with 40 angstroms, albumin cannot come out of, which is just around that. 60 angstrom is the albumin diameter, and at 40 angstroms, you could not expect albumin to come out. So this was supposed to be the answer why certain proteins are able to pass and others are unable to pass through, or macromolecules are able to pass or not pass through the slit diaphragm. Now, the current view is that the slit diaphragm is much more complex. Its central core is made of nephrin molecules coming from each of the adjacent podocytes. On top of that, there are Neph1, Neph2, and other molecules within that structure in transmembrane fashion. But there are some proteins which are not associated directly in the extracellular elements, such as podocytin, which is completely intracellular, or a completely extracellular, or mostly extracellular FAT1 and FAT2 molecules. So this is how we think the slit diaphragm in its current thinking is. It is possible to kind of summarize all these things in this particular diagram, showing basically the nephrin molecules lying in the center core and having lateral pores through which filtration does seem to be happening. It's a very diagrammatic version of things with other molecules kind of spreading along both NEF1, NEF2, FAT1, FAT2, etc. Very diagrammatic representation, but hopefully it will convey some element of reality to the concept of how the slit diaphragm allows passage of macromolecules. Now, on a different aspect, at a much higher resolution, at a much higher sophisticated level of thinking, this is actually a tomogram, electron microscopy tomogram of the slit diaphragm itself. Looks similar to what Karnowski had mentioned, but the pores, lateral pores, are not isoporous. They are of different sizes. And here's a molecule of the albumin, crystallized albumin, for comparison. For example, that molecule could not pass through this pore, but may very well pass through this pore. All of this, what it means is that probably the heteroporous model of slit diaphragm, which had been proposed after the isoporous model, is more relevant, and therefore meaning that in addition to the pore size and shape, the charge and other things may be important, how we allow or do not allow the passage of certain macromolecules out of the capillary lumen into the urinary space. What is podocyte injury and what happens to all of us when we are born, and by the time we die, what happens to those podocytes? This is a biopsy data from individuals, normal people, over time. And as you can see, the intersection of X and Y is at 580. So 580 in this particular model or this particular data set was the number of podocytes in each glomerulus at the time of birth, at time 0. And over time, there is a gradual decline of podocyte numbers. And then the decline is at the rate of about 2.3 cells per year. And that is normal. And if you can further extend the line, it still is a sizable number of podocytes that we might still leave even at the time of death. Interestingly, about 40%, which is a line that I have drawn in this particular graph, the blue line, is where the 40% decline of podocyte numbers stimulates fibrosis and glomerulosclerosis. So 40% loss of podocytes is the critical number. Once you lose 40% of podocytes, you are destined to develop progressive glomerulosclerosis. And that has been sort of replicated in biopsy samples. Again, this particular study was with Alport syndrome patients, where the decline in the podocyte numbers was translated into what the slope might look like. And quite honestly, the number of endowed podocytes at the time of birth in these patients was quite similar to 580 in this particular study. But the decline in the number of podocytes on a yearly basis was 26 podocytes per glomerulus per year, which is about 11 times higher than this, suggesting, therefore, that these patients reach a level of podocyte depletion at around 8 or 9 years. And from that point onwards, the decline is very progressive. They go through glomerulosclerosis and eventually in end-stage kidney disease. Again, reflecting that podocyte loss is a component of progressive renal damage, and therefore, whatever can be done to preserve those podocytes ought to be done. I've been tricked many times by my colleagues and asked, can you look in this slide and tell us what you think? And I would normally say, well, it kind of looks like a round cell, looks like a renal tubular cell. And then they would trick me back and say, no, it's not. Look at the immunofluorescent staining on these particular cells. And these are actually podocytes that you can actually stain with an antiserum fluorescent tag. And these are same stained fragments in various casts that are present in this particular urine. So you can actually see podocytes by special staining in the urine, but they're very, very difficult to quantify, even under most sophisticated circumstances. So they're not useful. Looking at the podocyte excretion is not a useful way of looking at the podocyte loss in any disease format. So this is really for interest sake. You can look at them, but you cannot really publish any data based on the podocyte numbers that are present in urine. One of the early suggestions of podocyte involvement in nephrotic syndrome came in an article that was published way back in 1975 from New York group. And they showed this particular diagram. It really reflects everything that's wrong with podocytes. They didn't know much what to call it. They just said that these are the findings. We don't know what it is. And these are patients with focal sclerosis. So if I were to re-look at this particular diagram, I see all the elements of podocyte injury in this particular podocyte. That was from a patient with FSGS. For example, this huge pseudocyst, lots of lysosomal pockets and fragmentation of the cytoplasm. What causes injury to podocytes? Many things. As you know, podocytes are mechanically stressed all the time with vascular expansion, contraction of the glomeruli. So mechanical stress is an important aspect of podocyte injury. Drugs and toxins, immune complexes, complement, cytokines, TGF-beta, FGF2, and reactive oxygen species. Any of those elements can lead to podocyte injury. As we talked about, gradation of podocyte injury, as we have talked previously, I will not go more into detail. Now, let's try and look into what do you see as podocyte injury when you have these electron microscopic pictures available to you. And again, this may be helpful in understanding what podocyte injury does to podocytes. This is a normal podocyte. Very nice, what I call as proud podocyte with a nice large nucleus and foot processes. Now, if you look at this particular podocyte, it's kind of shriveled up. It has a large cystic structure in the subpodocytic space. It has villous transformation of the cytoplasm all over and fragmentation of the cytoplasm. These are all features of podocyte injury, which in past we have not paid a whole lot of attention. I have listed these right here on this particular slide, and you can actually go through that in this particular diagrammatic representation. Basically, a sick podocyte with a lot of features suggestive of a dying podocyte. And eventually, these podocytes detach themselves, fall into the urinary space, and are actually excreted. The outcome of injury is very dependent on what happens next. You can either have recovery or you will go through sclerosis. The recovery process begins by these parietal cells coming in place. As you know, we've talked about the fact that podocytes cannot replicate themselves. Therefore, adjacent podocytes are unable to take on the task of healing this GBM, which is now denuded of podocytes completely. So the parietal podocytes, parietal epithelial cells come in, take place of those podocytes. They cannot function as podocytes, but at least they're patching up and preventing further injury. Well, if the mechanisms do not work, then there's excessive fibrin deposition and formation of scar that leads on to sclerosis of that particular glomeruli and glomerular death. This is an extreme example of podocyte injury in the form of collapsing glomerulopathy, as you can see the light microscopy picture. Diagrammatically shown here, the podocyte lost. Then the second step is invasion of the podocytes, invasion of the parietal epithelial cells into the space, in the Bowman space, and trying or attempting to bridge the injured GBM or exposed GBM. And this process will not succeed because there's an intense degree of inflammatory response, and eventually all of this is going to lead on to cirrhosis or glomerular cell death. A very simplified version of glomerular injury to podocytes. Sometimes when there is no depletion, you don't get much in terms of damage. When there is graded injury, all of that ends up in end-stage kidney disease. I promised you that I'll try and see if I can reclassify my own definition of podocyte injuries, podocytopathies. One thing I want to emphasize is that the end pathologic result of all podocyte injuries is threefold, or three types. Either minimal change disease, focal sclerosis, or you have mesangial sclerosis. These are the only three variants you will see. And different variants of FSGS, again, we will talk about that. But these are the three end results, either minimal change disease, focal sclerosis, or mesangial sclerosis. Now, from an etiologic perspective, many things can lead to all of this end result. These can be either permeability factor related, genetic defects, drugs and toxins, and hyperfiltration mediated. And we will go over each of those in a very quick succession. The circulating permeability factor induced podocytopathy. The clearest example of that is minimal change disease. In fact, Dr. Shalhoub, who proposed way back in '74, was an adult nephrologist at the Veterans Administration Hospital in Washington, D.C., and actually, quite frankly, lived quite close to where I used to live in when I was in D.C., although I have never met him personally. He proposed that there is an abnormal clone of T cells that expands, produces lymphokines, and then leads on to altered glomerular permeability. And how does that happen? Does it cause damage to podocytes? He had no clue, and he left it at that. And the evidence that he pointed out was remission of nephrotic syndrome after measles, which transforms T cell function, occurrence of nephrotic syndrome in Hodgkin's lymphoma, remission of nephrotic syndrome with drugs that impact T cells, such as corticosteroids and cyclophosphamide. And there is a whole host of data on recurrence of focal sclerosis in transplantation, leading to the speculation that there is a circulating factor in those patients as well. And then Dr. Regina Savin clearly took that and moved it further and utilized plasmapheresis in both treatment of focal sclerosis in native patients as well as transplant patients. I was somewhat of a critique of that approach. Most of those patients, native patients, were actually being plasmapheresed 3 times a week and had all the problems of FSGS in addition. And I would always say, why not do nephrectomy in those patients, go through dialysis and keep them on dialysis until they get better, or come to the point where we have better technologies available to retransplant them. So I was a critic for some time. Now, genetic podocytopathy, this is a critically important piece that clearly has bloomed in the last 20 years. But from a practical perspective, there are only 6 types of genetic versions that you need to be really worried about. One is the Alport syndrome, collagen defects. By the way, Dr. Tragosan, who discovered Nephrin, was also the one who discovered the Col-A 4, 3, 4, 5, etc. In other words, the Alport syndrome gene. So he had some background of all the podocytopathic lesions in his baggage, even before he discovered Nephrin. Now, why do we call this collagen defect as a podocytopathy? It's simply because it is this collagen that is actually renewed by the podocytes. It's manufactured by podocytes, and the switch from the juvenile variant to the adult variant. Juvenile variant is alpha 1, 2, and the adult version is alpha 3, alpha 4, and 5. That switch happens, and the key of that switch is actually within podocytes. And if the anchoring of the podocytes in this defective collagen doesn't happen, podocytes die. And therefore, this does become a part of podocytopathy. Then, of course, nephrin, podocin, and Wilms tumor 1. Please make sure in any clinical discussions in a very young child, 1 to 2 years of age, always have a look at the external genitalia with someone who has proteinuria and or nephrotic syndrome, because you will make that diagnosis of Denny's trash right there. And from a incidence perspective, perhaps podocin and nephrin dominate, but others are equally important, even though at a much lower. One of the data sets that Hildebrand and his colleagues on a worldwide basis looked at, and in their group of patients, nephrin was the dominant, followed by podocin, followed third was Wilms tumor 1, and placed 1 deficiency, and LAMP2 was the last of those. But these are the 6 types of genetic podocytopathies you have to care about, you have to look for in patients who might be presenting to you. Beyond that, there are many others. These are far less common, much more common in adults than in children. And I will not go through any of those. One misstep that I think is important to realize in describing the genetics of focal sclerosis, MYH9 was the first gene that was thought to be susceptibility gene for FSGS. But what turned out that the MYH9 gene intron and the APOL1 gene exon are quite close to each other. And what was the defect in APOL1 was initially thought that this was the MYH9 gene, and therefore MYH9 was thought to be the susceptibility gene. Well, as it now turns out, APOL1 is the actual gene, and MYH9 has nothing to do with susceptibility to focal sclerosis. Just a very brief review of why APOL1 gene might be important. We have a huge population of African Americans in this country, and that's what drives the discussion towards APOL1. From a historical point of view, as you know, Western Africa is where most of the slaves to the United States and Caribbean came from. This is also the reason why where the trypanosomiasis is very common. And it's believed that patients or people, population in this region have a high incidence of APOL1 that provides protection against trypanosomiasis. Just like in sickle cell disease, that provides protection against Plasmodium falciparum infection. APOL1 provides protection against trypanosomiasis. So when these people were brought into the United States, they carried that gene with them. And right now, the APOL frequency in the US is about 15 to 20% of population, the African American population. And this APOL1 gene now is very well known to be associated with not only focal sclerosis, but also predisposes these patients to HIV nephropathy, as well as sickle nephropathy. Just a word about viral-associated podocytopathies. The most important example that I can talk about is HIV nephropathy, devastating form of podocytopathy, which is very evident by a discovery of collapsing type of GN. Parvovirus does almost the same thing, and others can also do same sort of a damage. So viruses are an important trigger for podocytopathy or podocyte injury. Many drugs are associated with podocyte injury. Of these, non-steroidal anti-inflammatory are the prominent ones. Drug abuse, heroin particularly, was very well related. Bisphosphonates, amidronate, is very well known to cause podocyte injury. And drugs that we used, of those, rapamycin is really important. And hepatologists and neurologists use interferon for multiple sclerosis and hep C. Those are also somewhat injurious to podocytes and can cause direct toxicity of the podocyte and result in injury. Then hemodynamic disorders. As we know, glomerular hypertrophy is very common in someone who has low endowment of nephrons, such as in prematurity. Hypoplasia, renal hypoplasia, dysplasia, unilateral agenesis. All of those patients will have hypertrophic hyperplasia of the glomeruli, larger glomeruli. Obesity is a growing problem in this country. Cyanotic heart disease, sickle cell anemia. Again, we see quite a lot of that in pediatric population. Hypertension and diabetes are, again, an evolving threat in the adult population. And those are the factors that result in stretching, mechanical stretch induced, hemodynamically induced podocyte injury. This slide is to kind of bring focus into some of the different the genetic variants. Most of pediatric forms of podocytopathies become evident within the first couple of years. And again, first year has the largest number of podocytopathies, mostly because of congenital nephrotic syndrome and Podocytin deficiency that present at that time. Generally speaking, if you look at the entire gamut of pediatric podocyte disorders or nephrotic syndrome, about 30% roughly are due to genetic diseases. And the incidence kind of drops relatively quickly, and by the time you reach 12 to 18 years, about 10 to 15% of total patient volume would have genetic causes. Majority would not. Or at least we don't know yet. There may be genes that have still to be found out. The second part that I really want to emphasize is the fact that in adults, these different type of podocyte injuries occur due to various just genetic defects. But the interesting fact is that why did they not present during early years of their lives? And the hypothesis, therefore, in my view, ought to be that they have these genes, but they do require a second hit somewhere, whether that is a viral infection, whether that is a hemodynamic disturbance, something that causes a second hit, and therefore then activates these genes to lead on to either FSGS or other forms of podocyte injuries. So what we find as a genetic problem in adults, even though that is there, but often we have to look at a second hit phenomena, whether that's any medication or viral illness, we need to look into those. Some data has come from India in terms of podocytopathies. This is a very limited, this is from one of the Army hospitals, a very limited number of 15 patients in less than 15 years of age. Most of them were in older age groups. And their data suggest that Podocytin mutations are probably more common. Again, this is a very small number of patients. Interestingly, this was diffuse mesangial sclerosis. I'm not sure they have actually looked for WT1 mutation. I would seriously look at this particular patient and look for any WT1 mutation. These are some of the early data that have come through. This was a 2016 presentation. This year, there was a report from 12 pediatric centers. I'm not sure if any of you have participated in, and this is a summary of that particular data where 10 patients were found to have congenital nephrotic syndrome and had available information on their genetics. Of the 10 patients, 8 had Nephrin mutation, 1 had WT1, and 1 had place1. So emphasis, I guess, is beginning. I do understand it's very difficult and cost prohibitive at times to do gene testing, but I think that is the next stage we have to evolve ourselves into. Let's look at focal sclerosis, which is one of the most common forms of podocytopathy that we deal with. And this is the pathologic variant description. I apologize, for some reason, the slides are kind of acting up. So let me go over what do we mean by focal sclerosis and what are the variants of focal sclerosis that can be classified as podocytopathies. This is the Columbia classification of focal sclerosis. This is obviously the classic variant of focal sclerosis, with part of the glomerulus being affected by sclerosis and the rest of it being completely normal. This is the classic variant. Then there's the perihilar variant, wherein the efferent arteriole and the surrounding area undergoes sclerosis. This is something that usually happens in secondary forms, particularly hemodynamic type of situations, stretching, mechanical stress, etc. So whenever you see this type of a perihilar lesion, always look for other hemodynamic circumstances that might be leading to it. Then there's the cellular variant. This is a bit of a tricky type of a classification or subtype of FSGS. I apologize, something is going on with the slides, which I'm not sure what is. This type of FSGS basically looks as if it is still minimal change in a lot of places, but there is some endocapillary proliferation at times and some degree of sclerosis in other parts of the glomeruli. Perhaps this is an evolution from a minimal change, and it is transitioning into full-blown focal sclerosis. And if I see something like this in an African-American patient, I would say this is not minimal change. This is focal sclerosis. It is in a transitional phase, going through the cellular phase at this point, and eventually will develop focal sclerosis in its classic form. This is the TIP lesion, wherein the proliferation of the podocytes projects itself into the proximal tubule. You really need only one glomerulus present in a biopsy sample to then describe this as a focal sclerosis variant. That biopsy, even if you find one glomerulus in the biopsy, should be labeled as focal sclerosis with TIP lesion. Typically, TIP lesions are relatively more responsive to treatment and have less devastating impact. And this is the most devastating form of focal sclerosis, known as collapsing type. As you can see, the structure of glomerular capillaries is completely lost, and there is a significant and severe proliferation of cells. Most of these cells are parietal cells that have come to protect the denuded glomerular capillary basement membrane. And obviously they won't succeed, and this whole glomerulus will eventually become sclerotic. Virus-associated podocytopathies can present mostly with a collapsing form of nephropathy. This is recently described in COVID-19, again, collapsing form of podocytopathy. But this is parvovirus-associated podocytopathy that one of my colleagues, Dr. Asha Madgil, from my previous association in Washington, reported in 2001. And in fact, Dr. Baga was part of this particular study as well. Now, are there biomarkers of podocytes that we can rely on? As I reflected upon, you can see podocytes in the urine, but it's very difficult to make sense of that from a research point of view. But you can look at the podocyte markers in the form of nephrin, podocin, protein molecules themselves, or more precisely, actually, messenger RNA. These are the most promising tests that one can think about at this point of development. And hopefully in the next several years, some of these markers will become available for diagnosis of podocyte injury. This is a graphic representation of concordance of nephrin and podocin excretion in the urine, log transform, both of these, good correlation. So suggesting, therefore, that actually they can be utilized for, as a marker, both of these can be utilized as markers of podocyte injury. Do these markers actually tell us before the disease can actually appear? And the answer is yes. These are control patients, and these are diabetic patients who have normal albumin excretion, those who have microalbuminuria, and those who have gross proteinuria. Even before patients develop microalbuminuria, the level of the urinary podocin messenger RNA really goes up and rises even further up when there's obviously macroalbuminuria. So these markers are actually going to be helpful, and hopefully we will have those available to us for clinical usage. Again, the same type of a graphic representation of the podocin messenger RNA in various different forms of glomerular damage, autoimmune nephritis, SLE, MPGN, IgA. And again, you do see the rise in the level of messenger RNA for podocin in marker in those conditions. And these are, again, in need of validation and further exploration. So we do have some markers that are promising and might be available in the next few years. One of the kicks that I usually get is asking a question of the fellows and the residents and the attendings when I go on rounds is, we use a lot of corticosteroids in our lives, both in transplantation and treatment of nephrotic syndrome. Tell me, how do corticosteroids actually work? And why do they work? And I almost always get a blank look. Why are you asking this question? We all know they are immunosuppressive, but I really want to hone in on how do they work. There's a genomic mechanism of how corticosteroids work. As you know, they're lipid soluble. They transfer into the cytoplasm through the cell membrane very easily. Within the cytoplasm, they then bind to the glucocorticoid receptor, which is accompanied by a chaperone protein as it floats in the cytoplasm. Once the glucocorticoid combines with the receptor protein, the chaperone is thrown away, and the complex then is able to go into the nucleus by an importer mechanism. When the complex is within the nucleus of the cell, it attaches itself to what is known as the glucocorticoid responsive elements in the DNA sequence. And it does two things. It suppresses the pro-inflammatory genes and triggers an anti-inflammatory gene response. So suppressing the pro-inflammatory part and triggering the anti-inflammatory part, that's how they work. The transit time from here to here and the response that we develop is about 30 minutes. So glucocorticoids, you can't give anybody a shot of Solumedrol or hydrocortisone and expect immediate response. And that's why glucocorticoids are not utilized in emergency situations, such as allergies that may be fatal. You use epinephrine. That's why EpiPens are devised. So glucocorticoids do take time, and this inflammatory, anti-inflammatory action is actually mediated by genes within the nucleus of the cells. There are non-genomic mechanisms of corticosteroids as well. Those, sequestration and lipolysis is prominent, inhibition of various adhesion molecules, and stabilization of the lysosomes. And the net effect of both the genomic and the non-genomic mechanisms is that you have an anti-inflammatory effect. Next, coming to a very tricky part, how do we treat someone who has podocytopathy of some type? This is the adult component as reflected here by Dr. Jeffrey Kopp. Adults are treated by 4 weeks of steroid treatment, and if they fail, that is considered a no remission or partial remission if that happens, or complete remission if that happens. We all know how to deal with these complete remission patients. They may go through no relapses, about maybe 5 to 10%. They have rare relapses, and steroids are often utilized for that purpose. And if they have frequent relapses, you talk about CNIs, particularly tacrolimus, mycophenolate, or rituximab in that sequence. It is this group of patients that becomes a problem, those who do not respond to steroids. In pediatrics, I am a fan of the 6 weeks daily and 6 weeks alternate day steroid treatment, the German protocol. And most of patients who have nephrotic syndrome that's reversible with steroids will respond by about 4 weeks. 96%, the data clearly shows that about 95, 96% respond within 4 weeks. It is that remaining 4 to 6% of patients who may respond with additional 2 weeks of therapy. And if patient has not responded by 4 weeks, I start to get a little worried, and I often say to my fellows, sharpen the needle, and we usually talk about doing the biopsy. Once the biopsy is done, then they fall into one of 3 categories, either minimal change, or focal sclerosis, or diffuse mesangial sclerosis. And at that point, the decision tree for these 2 entities is still treating them with some form of either CNIs, renin-angiotensin inhibitors, and or rituximab. That's the pathway. It is the diffuse mesangial sclerosis and some focal sclerosis patients who definitely require genetic evaluation. These are the patients who either do not respond to any dose of anything that you have used, or those patients who have diffuse mesangial sclerosis, they definitely must look for WT1 mutation. So that's how I kind of work around what patients do I need to send for genetic mutation testing. Nowadays, we do have FSGS panels that are available as panels, and of those 6, 4 at least are easily doable. And after you have found out there is a genetic mutation, you basically do not expose them to any more of the toxins, the CNIs and the rituximabs and all of that. At that point, I typically would say, we need to go for a nephrectomy and dialysis, followed by transplantation. They are excellent candidates for transplantation because their recurrence, even though they have focal sclerosis, recurrence risk is 0. It just doesn't happen because these are all, and they do very well after transplantation. Just a very quick review of some of the studies. This is a study that was done in Delhi by Dr. Baga and Associates. It came out in 2012. And at that time, when it came in our discussion in our journal club, I said, why did they do it? And in retrospect, I do find excellent data within this study. All the gut feelings that I always used to have, and most nephrologists have, that cyclophosphamide provides remission in about 50% of patients. And tacrolimus gives you a much higher level of remission. And they have clearly published this data in a very cogent way, in a very thoughtful way. And I think that's the importance of this data set, both at 6 months and subsequently at 12 months, similar sort of a data profile that tacrolimus is a lot better as compared to cyclophosphamide. In fact, quite honestly, I have not used cyclophosphamide for almost 30 years now. I have switched over to either tacrolimus, mostly at this point. Cyclosporin is out of my picture again. I began with cyclosporin and then I switched over to tacrolimus simply because of various side effects, particularly facial hair in children. The second study that I really want to reflect upon is the value of rituximab, in particularly in steroid-dependent nephrotic syndrome. This data is from JAMA Pediatrics. It comes from Koketa. And this shows some significant relevance of rituximab in this set of patients. And not only this dependent nephrotic syndrome, but I think sometimes in steroid non-responsive patients, this could be tried. And even though I have resisted initially, I have been recently converted into thinking that maybe we should start using even in those patients. The superiority of rituximab versus tacrolimus is clearly shown in this database. Interestingly and importantly, what rituximab does is that you have a significant and a sudden drop of the peripheral lymphocyte count, which persists for about 15 weeks. And in this particular study, and the authors did not really emphasize this point, the non-relapsers actually had a lower lymphocyte count until a significant amount of time, about 40 weeks almost, in contrast with the relapses. So there may be a lesson to be learned that the degree of immunosuppression brought in by the rituximab, which is a CD20 marker attacker that affects the B-cell lymphocyte function. But is B-cell responsible for causing nephrotic syndrome? The answer is no. B-cell does not. But rituximab may actually have a different mechanism. In fact, rituximab does stimulate the sphingomyelin phospholipid diesterase like 3B protein, which is present in the podocyte. So its mechanism of action may not necessarily be it may actually be direct action within the podocyte itself. One aspect of treatment that is very popular within adult nephrologists in this country is ACTH and repository. I am dead opposed to that. I do not recommend it. This is a scam, and please do not help that company make fool of us as nephrologists. This was a drug that was, in fact, quite honestly, I actually asked Dr. My mentor in one of the rounds when I was a fellow, what did you use actually before prednisone came in? And his quick answer was, there were two drugs. One was thyroxine, and the other was ACTH before we had prednisone. And this is a very old drug, which is being repurposed for nephrotic syndrome. It's used mostly in membranous nephritis by adults. Very expensive therapy. Compare the cost. 10 milligram tablet of prednisone costs 10 cents, and it costs about $400,000 for a year's of treatment with this particular. So please don't encourage anybody doing that. And that brings me to the end of this discussion. I'll be happy to answer any questions at the end. I hope I have not exceeded too much of time.
Thank you so much, sir. It was really an enlightening talk. You really took us inside the podocytes. Probably we are hanged to podocytes now. Probably podocytes means we are hanged to podocytes means we are hanged to your talk. It was really an excellent talk, sir. Thank you. Thank you so much, sir. We'll take the questions towards the end of the session after the case discussion is done. Can we move on to the case discussion, sir?
I'll be here waiting for them. Yeah. I'll go through with you.
Yeah, today, we have our DNB resident, Dr. Priyadarshini, from Dr. Mehta's Multi-Specialty Hospital. Her special field of interest is towards general pediatrics and pediatric nephrology. She has received n number of honors, you name it, she has received it from anatomy, physiology, gynecology, general medicine in her undergraduation days. Over to Dr. Priya to present the case.
Thank you very much.
You're there?
Yes, ma'am. Thank you very much, ma'am. Big namaste to all the esteemed professors across the window. And thank you very much, sir, for the beautiful overview on a complicated topic. It is indeed a great privilege for me to present this rare case in this international forum for discussion. So this case is about a 9-month-old male child who is second born to third-degree consanguineous marriage, who presented to us with history of periorbital puffiness and abdominal distension since 10 days, history of decreased urine output for 7 days, no history of any high-colored urine, fever, skin lesions, or any native medications. His antenatal and natal history was uneventful. He attained age-appropriate milestones. He was immunized till age. Anthropometry, height, and weight were between 3rd and 50th percentile. Moving to the examination, general examination, he did not have any syndromic features. Had bilateral periorbital puffiness, bilateral pedal edema, abdominal distension. Vitals were stable. BP was normal between the 50th and the 95th percentile. Systemic examination, abdomen was soft, distended, bowel sounds were present, scrotal edema was present, other systems were normal. The initial investigation showed an urine albumin of 4+, serum albumin of 2.3, serum cholesterol of 223, and a urine protein creatinine ratio of 46.9, which fitted into the criteria of nephrotic syndrome. Other basic investigations like the basic initial renal parameters, urea, creatinine, electrolytes were within the normal limit. Other investigations done before initiating steroid to rule out immunosuppressions were done. Total count was 17,000. Differential count were within normal limits. Manto was done was negative. Chest X-ray were within normal limit. Ultrasound abdomen showed a normal-sized kidney with minimal free fluid in the abdomen. So child was diagnosed as infantile onset nephrotic syndrome as he presented at 9 months. Parents were also counseled regarding the need for renal biopsy in future. So initially he was started on fluid and salt restriction. For edema control, he was started on IV diuretics and albumin infusion. As per the ISPN guidelines, he was started on omnacotyl at 2 mg per kg per day, along with other supportive measures like calcium supplementation. Despite giving omnacotyl for 2 mg per kg per day, child failed to show remission at the end of 4 weeks. His urine protein continued to be 3+, serum albumin of 1.4, and a serum cholesterol of 232. Hence, he was labeled as steroid-resistant nephrotic syndrome, and a renal biopsy was planned. Renal biopsy turned out to be FSGS NOS type. In light microscopy, out of 9 glomeruli, there were 2 juxtamedullary glomeruli which were sclerosed. So based on FSGS, child was initiated on calcineurin inhibitors, the first choice being tacrolimus at a dose of 0.1 mg per kg per day, along with enalapril for control of proteinuria. Child did not show any clinical or biochemical response. Trough levels of tacrolimus were checked, which was found to be low, 2.3 nanogram per milliliter. Hence, tacrolimus dose was increased to 0.15 mg per kg per day, and fluconazole was added to get a synergistic action. But child did not show neither clinical nor biochemical remission. Hence, genetic study was then planned for this child. Since child was born out of a consanguineous marriage and child was initially termed to be as steroid-resistant nephrotic syndrome, a genetic study was done for this child. As the report of genetic study will take at least a month for the reports to come, we started the child on cyclosporin as there were few articles which showed almost equal efficacy of cyclosporin and tacrolimus. Hence, child was started on cyclosporin at a dose of 4 mg per kg per day. Trough levels were checked, which were within the normal range. Child was otherwise continued on other supportive measures like AC inhibitors and low-dose corticosteroids. Despite starting cyclosporin, child did not show any biochemical remission, though child clinically improved as edema decreased and urine output increased. Genetic report finally turned out to be positive. Genetic report was positive for NUP205, which is the nucleoprotein 205, which then the child was diagnosed to be as nephrotic syndrome type 13. Going to a brief basics on the genetics about this, there are two nucleoprotein, NUP205 and NUP93. Both of them complement each other. Both proteins combine together to form the nucleoprotein complex, which is an important part of the glomerular epithelial membrane. Defect in any of one of these protein can lead to disintegrity in the membrane. Both an integrated membrane will have a positive effect on the bone morphogenic protein 7, which helps in maintaining equilibrium between two signaling pathways. One is the SMAD4 pathway, another one is a transforming growth factor beta pathway. The SMAD4 pathway has an anti-apoptotic effect on the podocyte, whereas the transforming growth factor beta has a pro-fibrotic action. In this case, child had defect in the NUP205 gene. As a result, there was disintegration in the membrane, which had an effect on the bone morphogenic protein 7, leading to the disequilibrium in two signaling pathway, which led to the downregulation in the SMAD4 pathway and upregulation in the transforming growth factor beta. As a result, there was increase in apoptosis of podocytes leading to proteinuria and increased fibrosis, with the reason being explained leading to focal segmental glomerulosclerosis. This is one of the rare non-inherited form of steroid-resistant nephrotic syndrome. They usually manifest early between 1 to 6 years of age. There were few evidences which supported and showed partial response to cyclosporin and low-dose steroids. And this is a very new novel disease mechanism where the bone morphogenic protein 7-dependent SMAD signaling has a role in nephrotic syndrome, which is opening up new approaches in future for research. Though there is minimal proven evidence on the role of immunosuppressants in a genetic positive nephrotic syndrome, we continued the child on cyclosporin as few evidences showed that cyclosporin, despite having an immunosuppressant action, also had a podocyte stabilization action. Hence, child was continued on cyclosporin along with enalapril and a low-dose corticosteroids. In between, child had few intercurrent illnesses requiring hospitalization like cryptosporidiosis and bronchopneumonia. Parents wanted to try the last resort, rituximab. Parents were counseled regarding the cost, the side effects, and the prognosis even after rituximab. As parents wanted to try rituximab, we gave the child 2 trial doses of rituximab a week apart. After testing for all the serology and giving all important vaccines like pneumococcal, fluconazole, and flu vaccine. Pneumococcal, meningococcal, and flu vaccine. But child failed to show remission even with that. Child continued to have gross proteinuria, despite trying all medical management. So the next option in hand was medical nephrectomy. Indication for medical nephrectomy in this child where child continued to have gross proteinuria, low serum albumin level, intercurrent illnesses requiring hospitalization, probably because of proteinuria and loss of immunoglobulins. There was no indication for dialysis in the child as child never went for AKA or there were never derangement in the renal parameters. And in order to prepare the child for renal transplant, a medical nephrectomy has to be done. So we proceeded with medical nephrectomy. This is the biochemical chart of the child. In the course of the medical management with all the immunosuppressants, all the renal parameters of the child were very stable. Creatinine was found to be normal, so there was no any AKI requiring dialysis. So hence we planned for medical nephrectomy. Medical nephrectomy was tried with indomethacin, after which child glomerular function started decreasing, serum creatinine value started increasing, and serum albumin value also started increasing. So medical nephrectomy was done after the counseling and getting concern, but 2 months later, we lost the child due to sepsis and MOTS. Brief summary on this case is, in June 2019, we had this child diagnosed as infantile onset nephrotic syndrome. Child behaved as steroid-resistant nephrotic syndrome, hence renal biopsy was done a month later. Renal biopsy turned out to be as FSGS NOS type. Following FSGS, child was initially started on calcineurin inhibitor tacrolimus at 0.1 mg per kg per day. Child did not show any response, hence the dose of tacrolimus was increased. Despite that, child did not show neither clinical nor biochemical response. Genetic study was done. Child was diagnosed as nephrotic syndrome type 13 due to a genetic defect in nucleoprotein 205. Child was continued on cyclosporin as it has an additional cytoskeleton protection action. 2 trial doses of rituximab was tried. Child never showed any biochemical remission, continued to have gross proteinuria. Hence, medical nephrectomy with indomethacin was tried. But within 2 months of nephrectomy, we lost the child due to sepsis and MOTS. So questions put across for discussion is, could this child be managed better? What are the role of immunosuppressants? And what are the available modes of treatment till renal transplant? Though few questions have already been answered by sir, I put these questions across discussion. Thank you very much.
Kanwal sir, would you like to take up the questions? Can you add some points to enlighten us?
Sure. I think you have done quite well with this particular patient. When dealing with someone with nephrotic syndrome this early on in life, the odds of survival are quite difficult to overcome. No matter what you do, they have high instance of not only sepsis, infections, recurrence of edema, etc. They're also very prone to developing lots of thrombotic complications, which your patient certainly did not go through. My recommendation is when you know that this is a genetic variant, and I can give you one example where the parents of the patient, despite the fact that we proposed that this patient needed nephrectomy, dialysis, transplantation early on, was diagnosed at about 3 months of age. We went along with the parents' wish because they were opposed to transplantation. For many years, this patient was on intravenous albumin transfusions daily at home. Eventually, we did transplant him and did all the things that we were supposed to do. But the classic way in which I would deal with, because the sepsis issue crops up in these patients very constantly, and they usually die. To prolong their life and survivability, the easiest way is to do nephrectomy early on, put them on dialysis, then go for kidney transplantation, even though in your patient, medical nephrectomy was somewhat helpful. It doesn't cure all the issues. Particularly in a 3-month-old, for example, you have the volume of the belly where you need to put the transplant in. You need to make space for that. Uninephrectomy can be another approach that one can take, and we have taken that approach in some patients as well. That will curtail your proteinuria, give you some space, etc. So in my view, I usually take the course of going towards dialysis and transplantation early on because the odds are against you.
Fine. So we should have initiated the child, pushed the child for nephrectomy and put the child on dialysis till transplant.
That's what I would do. And you know, it's not easy to even talk about dialysis in these patients because you have to, as you go through nephrectomy, you have to go through hemodialysis. And to do hemodialysis in those tiny babies, you have to have the infrastructure to do that. That's one. Eventually, they go on to peritoneal dialysis for sure. But early on, you may have a very rocky course.
That's true. Okay. This child was only 7.2 kgs, so like hemodialysis option is ruled out. Probably we would have initiated the child on medical nephrectomy should have been planned earlier, and peritoneal dialysis would have helped the child till transplant. But then the child had very much like intercurrent infection was very frequently on and off. So we were also little, our hands were tied.
True.
Okay, so then the next case presentation is by Dr. Alpana. Can we take up the next case for discussion, sir?
Sure.
The next case for discussion is by Dr. Alpana Uri. She's a consultant in charge pediatric nephrologist at BJ Wadia Hospital. She's also associate professor of pediatrics. She's a consultant pediatric nephrologist at Jasluke Hospital. Her interest is towards critical care nephrology and dialysis. And she's received the best undergraduation in her MBBS days. And she's also a DND pediatric gold medalist. Over to Dr. Alpana Uri for her case discussion.
Good evening, everyone. I would, without wasting time, directly proceed with the presentation. Since we have had a beautiful discussion on podocytopathies, I've tried to remain limited and selected my patients according to the same diagnosis. Case 1 was of a 12 years old female who presented with history of fever on and off for 1.5 months, rash for 1.5 months, swelling over the body for last 15-20 days, and was admitted outside and treated as scrub typhus. On examination, she had the typical rash, which was a malar rash, photosensitive, and there was also a generalized rash all over the body. The vitals of this child were stable, normotensive, well grown. On examination, she had pallor, there was generalized edema, lymphadenopathy. She had oral ulcers, rash over the body as described. And on systemic examination, she just had diminished air entry in the both inframammary areas, suggestive of pleural effusion, and the rest of the systems were normal. On investigations, over the next 7 days, her hemoglobin was normal to start with, dropped by 1 gram over 7 days. She had leukopenia on one occasion. The platelet count was less than 1 lakh, hovered between 70 to 80,000. Her biochemistry was suggestive of full-fledged nephrotic syndrome, serum albumin of 2.1 and cholesterol of 315. Urine albumin showed for nephrotic French proteinuria, but there was no microhematuria. On quantification, 24-hour urine albumin was again in the nephrotic range. Because she was looking like SLE, so a relevant immunological workup was sent. Her C3 and C4 both were low. ANA was positive, 1 in 1,000, but dsDNA was negative. We sent the ANA blot, which showed anti-Smith to be positive. She was worked up for pro-coagulant state workup. APLA, ACLA, and lupus anticoagulant was negative, but beta-2 glycoprotein was positive. Her direct Coombs test was also positive. USG abdomen showed pleural effusion as well as mild pericardial effusion on echo. Going by the revised Euler criteria, she fitted completely into SLE with a total score of 32. Requirement is 10 out of the total score of 53 for classification. A renal biopsy was done, and we were fully expecting a membranous kind of picture, class 5 lupus nephritis, but instead it was reported as a lupus podocytopathy. Now, what is that? The light microscopy showed mild mesangial proliferation, and on immunofluorescence, though there was full house immune deposits which were seen, but they were very scanty along the capillary loops. There was some in the mesangium. On electron microscopy, there was diffuse effacement of foot processes. Again, there was no EDDs, no sclerosis, no features of glomerulonephritis. So we had a child who was SLE, according to revised Euler criteria, was having the nephrotic syndrome, but had near normal light microscopy, near normal immunofluorescence, and diffuse foot process effacement, a term which is called lupus podocytopathy. First, describing what is lupus nephritis, all of us are aware that about 40 to 80% of children with SLE have lupus nephritis, and the hallmark of lupus nephritis usually are the proliferative lesions, usually endo or extracapillary, full house immune aggregates, and copious subendothelial and subepithelial deposits. Classification is into class 5. This is according to the ISN RPS classification. And the first two are showing usually mesangial lesions. Second one is mesangial proliferative, then diffuse proliferative, focal and diffuse proliferative, last membranous, and then sclerosing. So most commonly, if you think of lupus nephritis, you think of proliferation, necrosis, and you think of subendothelial deposits. So this girl was behaving atypical. Now, to describe, many of us have come across this dilemma that patient has SLE, she has heavy proteinuria, but she does not fit into any of the histological classes. Probably recognizing the same thing, a new entity called lupus podocytopathy has been coined. It is not yet included in the current classification of ISN RPS, and the prevalence is about 1.3 to 1.6%. Proponents of this entity have also proposed criteria. The clinical criteria being you have to have SLE, you have to have nephrotic range proteinuria. Light microscopy may show minimal change, mesangial proliferation or FSGS, but IF only must have mesangial deposits and not capillary deposits. And EM has to have foot process effacement to the tune of 50% or 70% or more. And there should be no capillary deposits. Mesangial deposits are permissible. So people say, why is it not possible that it's minimal change and SLE happening in the same person at the same time? Is this actually a fortuitous association or is it linked? So epidemiological probability of the two diseases happening in the same person at the same time is negligible. And also it has been seen that lupus nephritis patients who are having a nephrotic flare also are having extrarenal lupus and serological flare at the same time, indicating that the nephrotic is linked to SLE and not a separate entity. Now, how do you differentiate lupus podocytopathy from class 1 and class 2? Both of them have no capillary proliferation and no capillary deposits or negligible capillary deposits. But lupus podocytopathy usually clinically has either nephrotic range proteinuria, often AKI, and morphologically can be MCNS, mesangial proliferation, even diffuse proliferation. Usually, the foot process effacement in lupus podocytopathy is more than it is seen in class 1 or class 2. So this classification also has clinical implications that unless you recognize it as a separate entity, there is a possibility that these patients receive only monotherapy and suffer high risk of relapses. Almost 52% have been reported as compared to 24% in class 2, because class 2 often receive more than one drugs, so they are better off. Also, lupus podocytopathy patients are known to have higher incidence of AKI. Mechanism how this happens is due to dysregulation of podocyte actin cytoskeleton and possibly a crosstalk between parietal epithelial cells and immune cells. This results in a podocyte injury, foot process effacement, loss of podocyte specific markers, and cell detachment. These are a few published studies on lupus podocytopathy. For those interested, can please go through this. Going on to the second case hurriedly. This was a 13-month-old female who presented with loose motions, fever, and decreased urine output. She was born out of third-degree consanguineous marriage, was average weight at birth, and no specific perinatal events, well grown, and there was developmental delay in the motor domain. Examination was, there was tachycardia, tachypnea. She was hypotensive at admission and was also lethargic, had required 2 dextrose, 10% dextrose boluses. There was generalized edema. She also had deeply hyperpigmented body. Genitals were normal. She was fluid overloaded, and there was also generalized hypotonia, which was noticed. Her investigation showed a pancytopenia. CRP was non-reactive. There was hyponatremia, hypokalemia, azotemia, and lactate was 1.8. She was acidotic. Biochemistry all this time was of a nephrotic syndrome. USG showed bulky kidneys with loss of CMD. Upfront, when we came across this child, we first thought it may be an ATN, the usual stuff. But when we recognized the nephrotic status and 4+ albuminuria, we thought maybe it is HUS. But then the HUS workup was like there was no picture of Maha-like situation. So we thought it's possibly C3GN, but C3 was 116 normal. It still could be a possibility because some of the times there is no quantitative defect, but there's a qualitative defect. And last, we also thought of diffuse mesangial sclerosis because we had seen a similar case earlier. But there was some differences from a usual podocytopathy. The child had severe hyperpigmentation and hypoglycemia besides the nephrotic syndrome and the AKI. So endocrine workup was also sent, and to have low serum cortisol, low aldosterone, and raised ACTH. Even thyroid workup was suggestive of primary hypothyroidism. The child was started on hydrocortisone and thyroxine supplements, supportive therapy, initiated on PD, given for 3 days, did not open up. Break of 2 days, and again second PD was done, still remained oligoanuric. All this time to have nephrotic range proteinuria. Hence, a biopsy was done. Biopsy did not show any glomeruli. Interstitium was edematous. Tubules showed hydropic changes with vacuolated cytoplasm. Vessels were unremarkable. There were no immune aggregates seen on biopsy. We now had a child who was actually having a progressive nephropathy with a polyendocrinopathy and a developmental delay. Since we had already seen a similar case, but we had not done genetics earlier, I was pretty much convinced that the child was having SGPL1 mutation leading to a nephrotic syndrome type 14. So we did not really, we kind of counsel the parents accordingly that it's likely to be a genetic condition. So we did not pursue for very aggressive management, and after some time the child developed sepsis and required mechanical ventilation and all, but we did not push it too far, considering that it was the first child and it was a very grim disease to have. Post-mortem biopsy was done again because we wanted to have the light microscopy picture. It showed 31 out of 39 glomeruli to be having FSGS with a lot of IFTAs. So we also did the genetic diagnosis and we found that the child was suffering from nephrotic syndrome type 14. It is due to a SGPL1 mutation in the 11 chromosome number 11, and the child was homozygous for this. So this is one of the many studies on the same subject. Nephrotic syndrome type 14 is due to SGPL1 mutation, which is an enzyme of single lipid catabolic pathway, and a loss of function mutation leads to accumulation of lysosomal sphingolipids, which are present all over the body. So it has multi-system affliction. There is primary adrenal insufficiency, hypothyroidism, immune deficiency, skeletal defects, and a progressive nephropathy. A patient may have all of the above, but usually the two most important things seen are the endocrinopathy and the nephropathy. So the prime target organs in such patients are the podocytes, and they can cause a congenital nephrotic syndrome, infantile onset nephrotic syndrome, or even afflict the child while still in utero, causing a fetal hydrops. Obviously, these patients are unresponsive to steroids as it's a genetic disorder, podocytopathy, and they show early progression to CKD. Histology may be DMS, diffuse mesangial sclerosis, or an FSGS. So this child was given symptomatic therapy. For this endocrinopathy, he was given replacement therapy with steroids and thyroxine. For immunodeficiency, was given IVIG for a little time till we got convinced of it being a genetic etiology, and some prophylactic antibiotics. And nephropathy in these patients is steroid unresponsive, as I said earlier. And whenever the CKD sets in, conservative management is done. Renal transplant has been reported in such patients only in 6 patients. Overall, only 39 cases have been reported in the world so far. Transplant was done in 6 of these patients. 2 out of them required second transplant and 1 expired, and there's no literature on the 3 other ones who were transplanted. There is some mention of enzyme replacement therapy in such patients, but that is still experimental. Thank you. I hope I didn't exceed the time. I was given 12 minutes, and I think I finished the 2 cases in 12 minutes, Dr. Kalaivani. Any kind of questions on these 2 patients? Well, I'm most willing to answer.
Thank you so much, Dr. Alpana. It was an interesting case indeed. Kanwal sir, do you have anything to add on in these 2
Not
cases?
really. I mean, they have done everything that needed to be done in the sequence that it needed to be done. I think it's very commendable that they were able to, even at late stage, make diagnosis. Obviously, if the biopsy would have been successful early on, you would have had the histological picture before you. But they did what they needed to do. These are difficult patients. And again, the use of cyclosporin in some of these patients is a little bit tricky, but at least there are several papers talking about the use of cyclosporin as an enhancer of the cytoskeleton. Not a convincing database, but that can certainly be tried, as your first presenter reflected upon, in a non-specific way. In about 25% of patients who have any number of these genetic mutations, you might see some success with those modalities. 25% roughly is the number of patients who respond reasonably well, at least with partial remission. 75% don't. So it may be worth trying that at least upfront in some of those patients.
Sir, we have a few questions from the... Yeah, Dr. Alpana.
No, this patient came during the first lockdown of the COVID season, and we did try to, after the second PD, for the sake of brevity, I had made it very brief. We did try to manage a single cuff catheter and initiated on peritoneal dialysis. We were hopeful that prior to counseling the parents against for a definitive aggressive therapy further on, we wanted a genetic diagnosis, but we wanted a histological diagnosis, but to our dismay, biopsy did not reveal any glomeruli. And I was also very amazed to realize that although only 40 cases have been reported in the world so far, even I have seen another absolutely same kind of case about a year back. But in that particular child, we were neither able to do biopsy, nor we were able to do the genetic, because the mother was already pregnant with the second child. So she said nothing doing, because it would be a great family dilemma as to what is to be done. So, but the child had, that child even had immunodeficiency and skin lesions. So it was a whole thing kind of thing. So here upfront, we were able to diagnose because we had seen a similar case earlier.
You've done exactly what I would have done.
Sir.
You've done exactly what I would have done.
Thank you, sir. Thank you so much.
We have few questions from the participants, sir. Can we take up the questions?
Sure.
Is that fine, sir? First question is, in congenital nephrotic syndrome, we recently used supranormal dose of enalapril and would normalize the serum albumin. The proteinuria has resolved and the creatinine remains normal. This child had NTHS1 heterozygous mutation and also had CMV, IgM and IgG positivity with intracranial calcification. There was not much response to Valgan cyclovir. What is your experience with supranormal enalapril or RAS inhibitors blockade in such patients?
I don't know what supranormal or pharmacological use of those drugs really means. Once you have inhibited, for example, that enzyme is completely blocked by a pharmacological dose, any addition of ACE, or for that matter, even R, gives you nothing output-wise, will not further, in other words, because you have maximally blocked those enzymes. You will not get anything more. What you're adding basically is toxicity of those drugs, bone marrow toxicity. So I am not a great fan, because once you block those enzymes, that's it. And using higher doses does not really do anything.
That's true. Even in our case, what we discussed, we had the child on enalapril, but we do not have the scope of increasing it further. We just stopped with 0.6 mg per kg. We did not have the liberty to increase it further, thinking that it would have toxic effects. So we added indomethacin to just do a medical nephrectomy.
I have to say, my indomethacin has been relatively poor. It does, in my hands, it has not been very helpful, but obviously you succeeded in getting this patient to where that patient needed to be. But I am probably a combination of RAS and indomethacin probably is a better option.
Okay, sir. And the next question is, children with minimal change nephrotic syndrome, even those with recurrence over many years, recover completely. A circulatory factor has not been found. How does the podocyte recover? This question is from Dr. String. Yeah, sir?
Great question. It is obviously an enigma. How does steroid therapy work in these patients? And again, I'm diverging from what's the classic view, which is that the classic view would be that it is an immunosuppressant, therefore it works. My view is that somehow, somewhere, steroids have an impact on the cytoskeletal structure of the podocytes themselves. And in fact, there is some evidence for that. There are some data actually suggesting that steroids actually have an effect on the actin molecules themselves. So my point of view is that in addition to the immunosuppressive thought process, these drugs may actually have an impact on the cytoskeletal structure itself, and more work needs to be done. There's some evidence for it, but it's not convincing all the way.
Okay. And the next is from Dr. Srinivasan, sir. He is just saying a hello to you, sir. The next question is an excellent presentation. Would you comment on podocytopathy in lupus nephritis and other conditions such as membranous nephropathy?
Well, from a point of view of a descriptive terminology, all of those disorders eventually lead to podocyte disintegration. Lupus is clearly one of those diseases where immune complexes will damage those podocytes. Same is true of membranous nephropathy. And therefore, they will go through, as I have outlined, all of those elements of damage ultimately result in disruption of the signal transduction, inflammatory output, and therefore damage of the actin myosin cytoskeletal system. So in the end, you have the same cascade going into the destruction of podocytes. in the end, you have the same sort of a process. Podocytes will detach, go to apoptosis, and then you will have cirrhosis. That's the pathophysiology of cirrhosis in general.
Okay, so the next question is, I think the question is little directed towards Dr. Priya for the case 1. The genetic variant is the variant of unknown significance. I think we have already mentioned this genetic positivity is mentioned as heterozygous, but if it had been homozygous, it carries a lot of positivity. And she has put a simple flow chart. Dr. Priya, would you like to explain the flow chart?
Yes, ma'am. Actually, separately, NUP 205 and NUP 2093, they combine together and maintain the membrane integrity. So defect in either of the gene can cause this membrane dysregulation and increase the apoptosis and increase fibrosis. So both these two nucleoproteins go hand in hand in maintaining the balance between them. So though singly it does not have any significance, but when combined with NUP 93, it does have some impact causing fibrosis and leading to FSGS.
Yeah, true. I think it answers the question. Next is fluconazole addition for the increment of tacrolimus effect is an interesting new knowledge for me. Is it routine or case-based? TAC drug blood levels measured and increase or decrease accordingly in our way of management. I think like Kanwal sir, we routinely add in case the child is not having good response with good dose of tacrolimus. Then we add for the synergistic effect, we add fluconazole or diltiazem based on the child's nature. Is that practiced in your place, sir?
Fluconazole, we often do in patients, particularly African Americans, have an increased metabolic pathway for African metabolism, and the levels cannot be maintained well. There you add fluconazole, and that's the only purpose of fluconazole, is to raise your plasma levels when they are unsustainable. That's as far as it does, just to boost your tacrolimus level.
Dr. Kalaivani, can I just make a comment?
Yeah, sure.
This cyclosporin has a lot of has a hepatic metabolism through P4-550 cytochrome pathway. So all the agents which are interfering with that pathway increase the levels. The problem is, if you are giving the two concurrently, the increase in the levels will not be very predictable. Whereas if you are using tacrolimus in a dedicated fashion and you are titrating the dose, meaning changing very little at a time, 0.25 milligram in a whole day, etc., then you can expect some kind of predictable response. Whereas when you're using two drugs concurrently, it's not a very predictable level and it can lead to toxic levels. So as a general, it is not used. But to say that also, even TAC pharmacokinetics, sometimes there are patients where you use 5 milligram TAC each BD, still you don't achieve therapeutic levels, because individual variation in pharmacokinetics of tacrolimus is also immense.
A lot of high metabolizers, low metabolizers.
Some cases we do kind of use these drugs in that situation. Otherwise, they are to be generally avoided.
I think he or she, the doctor, has been very much pertinent to this case. And in our case, along with, it was not a combined drug, tacro and cyclosporin. Initially, it was only tacrolimus. We did not achieve a good draft level. So we had added fluconazole to increase the levels. And subsequent levels was normalized. The cyclosporin was added subsequently, not because tacrolimus did not work, rather because genetic was positive. And in many literature search, we found that cyclosporin acts on cytoskeleton.
Stabilizing effect on the cytoskeleton.
When the child was on cyclosporin, fluconazole was not continued. And the next question is there a role of unilateral nephrectomy in such a case? Kanwal sir, is there anything to add on?
Sure. No, I can certainly address that as an issue. Once you have made the diagnosis of a genetic variant, as I said, the likelihood of you getting to a good response and a good outcome in the patient is relatively low, especially in a child who may be 3 months, 4 months, 6 months old. Therefore, doing a nephrectomy is helpful in reducing the amount of protein loss and preventing thrombogenic complications. Both of those are equally important, and raising the level of your immunoglobulin in circulation and therefore preventing sepsis, et cetera, issues. Now, sometimes you are faced with a patient who you would like to preserve the renal function, not go through hemodialysis in that young age. And at that circumstance, doing a unit nephrectomy makes a lot of sense. And this is particularly helpful in patients not podocytopathies or any of these congenital genetic issues. It's also equally effective in patients who have polycystic kidney disease. You create space, you maintain the renal function, put them on dialysis until you get to the level of transplant, let them grow. So yes, there's a role for a uninephrectomy in some of these patients.
Okay. And the next question is comment by the expert, please. I am an endocrinologist who co-managed this case.
That is from, I think, head of the department and a very reputed clinician, Dr. Sudha Rao. She's the head of endocrinology in Wadia Children's and also is the head of the pediatric department.
That's great.
And Madam would second that we had diagnosed this child much earlier than the histopath and the genetic thing, because she was also the person who looked after the initial case, as I said, about a year back, who had the same kind of picture.
And so she wants to know whether the outcome of endocrine disturbances, is it going to be lifelong or it is just a short term? Kanwal sir or Namalwar sir, do you have anything to add?
I have no experience of long-term issues at all. I don't have any expertise.
Ma'am, since this is ma'am, since it's a progressive disorder, because it will keep on accumulating unless you unless enzyme replacement therapy becomes possible and becomes commercially available. Till that time, you can expect that even if such patients are transplanted secondary to their progressive nephropathy, the other systems will keep on becoming more and more dysfunctional because these sphingolipids will keep on accumulating because the enzyme is just deficient. So it is a lifelong therapy. That is why we were not really proposing renal transplant, because the other organ systems will continue to manifest problems unless ERT, enzyme replacement therapy, is also kind of brought in. So it was a long story for the family, and it was the first child. So we wanted them to kind of go in for another normal child after prenatal diagnosis rather than struggling with a child with so many multi-system affliction.
If I may add, touched upon enzyme replacement therapy, Fabry's disease is just like that.
Yes, sir.
You have glomerular disorder, tubular disorder, and other organ dysfunction. Unless you do the enzyme replacement, progress and prognosis is really poor in those patients.
Okay, sir. And the next question is also from endocrinologist, Dr. Alpana. What has been the long-term experience in such cases?
In cases with same patients, I have experience of only 2 such patients till date, and only 40 cases have been reported in literature. So the endocrine experience in those reported 40 patients is that the long-term this endocrine replacement therapy has to be on, depending upon which all endocrine organs are afflicted. And when you come across one affliction, you kind of look for other affliction well, because the most important component of this syndrome, NPHS 14, is adrenals and kidney, but thyroid is the next most important, frequently endocrine organ which is afflicted, but others can also, hypogonadism, etc., has also been described.
Okay. I think we are done with the questions, sir. Like now I call upon Dr. Namalva sir to deliver the vote of thanks. Namalva sir, you're there, sir.
Can you hear me now?
Namalva sir? Yeah, we are able to hear you
me?
now, sir. Yeah, we are able to hear you, sir. We are able to hear you, sir.
Okay, more about I'm really honored to be invited to provide the concluding session.
Sir, like you can switch off your video, sir, because your audio is getting disturbed. We are not able to hear your audio, sir. So that the audio clarity becomes better if you switch off your video. Is that fine, sir? Namalva, sir?
Okay. Can you hear me now?
Yeah, we are able to hear you now, sir. Sir, you're there? Namalva, sir? Sir, you're there, sir? Extremely sorry. Just 1 second. We'll just try connecting with Namalva, sir, again. Sir,
Yeah, here.
you're able to hear now, sir?
I'm able to hear you, ma.
Yeah,
Do you
sir.
hear me? Can you hear me?
Yeah, it's very much audible, sir.
I am honored to be invited to provide the concluding session.
Sir, can you switch off your video, sir? Your audio is so much disturbed. Can you switch off your video, sir? Namalva, sir? You can switch off your video, sir, so that
Can you hear
audio
me?
is better heard. Yeah, now it is better, sir.
In a convention, 200 or to about 1,000 other delegates. Talk was for leadership. I had.
Sir, we are not able to hear you, sir.
For me,
Your voice is breaking, so we are not able to hear you.
visiting my home, my memory. Either COVID-19 will not. Means Dr. Vivekananda gave the world to himself by love and wisdom. When he addressed the congregation,
Sir, your audio is so much breaking, sir. We are not able to actually hear you at all, sir. I think Kanwal sir, I think Namalva sir's audio and video, the audio is not audible. Can we close the session, sir?
Absolutely. Please go ahead.
And I just wanted to say a big thank you to all the faculties and participants. I really thank the Almighty God for making this webinar series a resounding success. This event on the whole was like a dream come true. At the end of every hurdle, we have a big reward awaiting for us. The same way, this COVID has brought us together to the online platform to make us share knowledge. And this 3.5 months had been a wonderful journey working with everyone. It was a new learning experience for me personally and professionally. I felt pediatric nephrology in me had reborn and redefined and taken a good shape to fly high. Hope it had been a good training module for all of us. I really thank this opportunity. A big thank you to all faculties and participants who had been a pillar for the success. We have received almost many questions, and each question and answer session was like a new chapter for us. And thank you all. I take this opportunity to thank each and everyone. Thank you all. Wish you all a very happy New Year 2021. Thank you so much, Dr. Alpana. Thank you so much, Dr. Kanwal sir. It was really an excellent session. Thanks, Dr. Priya, for giving us an interesting case. Samantha, do you have anything to add on?
Thank you so much, Dr. Kalaivani. It was actually a pleasure. Thank you.
Thank you
Well,
so much.
Thank you all for having the patience to listen to this very long presentation. It was truly scratching the surface for me, but you had to do what you had to do within the constraints of time. I hope you enjoyed it, and I hope you learned a little bit of new things.
Yes, sir.
Thank you, sir. Thank you.
All right, take care. Bye-bye.
Thank you.
Take care, sir.
Bye.
Bye, Dr. Alpana. Bye, Kanwal sir.
Bye, Priya. Bye, Dr. Kher. Bye.
Thank you, ma'am.
Thank you.